Hello and welcome to a special interview for The Wire. In a few days, India will have over 1 million COVID 19 cases, but that is just the official tally. The tally of undetected cases by now could be as much as 140 or 150 million. So, are we in control of the situation? That's the key issue I shall discuss today with the CEO of the Wellcome Trust DBT India Alliance and one of India's foremost virologists, Shahid Jameel. Dr. Jameel, as of this morning, Tuesday the 14th, India has crossed 900,000 cases. In a couple of days, we'll cross 1 million. We're increasing at 28, 29,000 a day. And in terms of cases, we're the third largest country in the world. Doesn't it seem that we are not in control of the virus?
Well, India is a big country, so it depends on how you look at it. Uh, yes, having almost 1 million cases is worrisome, but I think the rate at which our cases are increasing, roughly 3% daily increase, tells us that at least we are not on a runaway train. We have a train which is still being driven. So there are things that we can do better from here on, and that will help us control it even further. Uh, yeah.
Let me come to those in a moment's time, but let me first put to you the implications of the serological survey done by the ICMR. The results were officially announced on the 11th of June, and those results showed that as of the end of April, India had 0.73% of the population who'd been infected, and that is 10 million people. 75 days have passed since the end of April, and at a doubling rate of 20 days, that would suggest that the figure of people who are infected is something like 140 or 150 million. Would you agree?
Well, yes, if the ICMR numbers are correct, if that zero survey is correct, and one has no reason to believe that it's not correct, then what you just said is right. But there are, other ways of calculating how many cases we have today. Zero surveillance by ICMR is one that you just pointed out. Uh, I will maybe give you two or three other ways of calculating. The second way of calculating is again based on ICMR's own data, where they said that from the same survey, they said India has 0.08% infection fatality rate. If that were true, today we have 23,727 deaths. And if that is reference to the 0.08% infection fatality rate, that comes to about 30 million infections now. So you see, here is the problem. The same study tells you of a zero positivity rate and a death rate, but when you translate that into infection numbers, they don't match. They are in fact off by about 5 times.
Right.
So this is the continuing challenge that people are facing.
But this
Let
is
me go to two other models
yes.
before I stop here. The other is something that I call a death model or a hybrid model, and I have also published this in a piece for the Observer Research Foundation in May. The death model simply assumes that there is an infection fatality rate of 0.5%. And this is based on studies done in California, in Texas, in New York. These are studies that were published in Lancet. Lancet gave a zero prevalence of 0. Of an infection fatality rate of 0.6%. So let's assume it's a 0.5% fatality rate. Then we simply multiply the death by 200 because it's 0.5%. So you multiply it by 200, you will get a number, but that number of infections was 18 days in the past because it takes on an average 18 days from a person being tested positive to dying of COVID. And if I use that metric and calculate, my number comes to somewhere in the range of 8 to 10 million infections. And if I may, there is one other model that has been proposed by a mathematician by the name of Murad Pamji. And his model again rests on a 0.5% infection fatality rate, but then he also takes into account what is the delay between case identification and fatality, or rather the reporting between somebody dying and being reported as death. And in a scenario where there is a 2-day difference or a 7-day difference or a 10-day difference, his numbers show somewhere around 20 to 50 million infections in India today. So you have a whole range. Uh, you have 20 to 50 million proposed by Bamji. You have about 10 million that I calculate from a very simple death model. ICMR, from its fatality rate, calculates about 30 million infections now. And ICMR, from its sero survey, tells us that it's a roughly 150 million. So that is exactly the problem. We don't know what is the correct number. And
Absolutely.
that's why I took so much time to explain this.
I'm very glad you did, Dr. Jameel, because what you've managed to convey perfectly is depending upon the model that you use, the outcome in terms of how many infections there
Right.
will be can vary from 8 to 10 million at the low end to
Right.
150 million at the high end, which
Right.
means that you have to decide which model you want to go with and put your faith in it, and then you come to the answer. But
Right.
depending on which model you choose, the answer can be very different. Let me put something else to you. I'm sticking for a moment to the zero surveillance model of the ICMR.
Okay.
Now, as you know, as the number of cases increases, so too does the doubling rate. If we assume the doubling rate goes up to 30 days from 20, which is what it is today,
Right.
the 140, 50 million will become in 2 months' time, by the middle of September, 560 million, which is pretty close to half the population of India. On the other hand, if you assume that the doubling rate becomes 40 days, then 140, 150 million increases to 350 million, which is roughly one-third of the country's population. And I know this is entirely based upon the sero-surveillance projections of the ICMR. But on that basis, are these numbers worrying because they are so big? Or do they, in a way, suggest some reassurance because we're getting closer and closer to herd immunity levels? Which of the two?
Yeah. Uh, so first of all, let me say that all models are wrong, but some models are useful. Uh, any model depends entirely upon the assumptions you make and the data that is available to you. So I keep coming back to the fact that the data that is available is not very granular. Let me give you an example. If one says that Delhi is currently doing 100,000 tests a day, let's assume that Delhi is doing, or let's say 10,000 tests a day. If Delhi is doing 10,000 tests a day, I don't know how many of those 10,000 are confirmed RT-PCR tests, how many are antigen tests. Because by ICMR's own admission, I know that uh, the sensitivity of the antigen test ranges only between 50 to 80%.
Can I interrupt there, Dr.
Yes.
Jimmy? Yesterday's Hindu, that is to say Monday the 13th Hindu, actually did break it up. They said that on Sunday,
Mhm.
something like 11 or 12,000 antigen tests have been done and 9,000 RT-PCR. Or maybe it is the other way around. I'm saying it from memory, but yesterday's Hindu, and I imagine the information is given by the Delhi government, did break it up.
Okay, so if that's the case, then if the sensitivity of the test is only about 60% and 50% of your testing you're doing with that test the numbers are not very reliable.
I
That's
understand the
what I'm
point.
coming to.
I understand the point you're making that depending upon the sensitivity, you have doubts about the reliability of the numbers. But let's leave that aside because that would apply, I imagine, to RT-PCR tests at any time in India and probably anywhere in the world. Questions can be raised about their sensitivity. But what about the projection that I put to you? That if you take a doubling rate of 30 days, the 140, 150
Yeah.
million by the middle of September becomes 560 million. If you take a doubling rate of 40 days, the 140, 150 million becomes 350 million. Is this worrying because it's huge? Or is it in a some way reassuring because it's one step closer to herd immunity?
No, I would say it's worrying. Uh, if those numbers are correct, they are worrying. And normally I would have said that yes, we are getting close to herd immunity, and therefore it's good. But then, even the herd immunity data is very mixed. Uh, you will, a paper has just come out on 11th of July. It's in the preprint, and it shows that the neutralizing potential of serum or plasma from recovered patients wanes in about 4 months.
That's right.
So it raises many implications for vaccines, for plasma therapy, for herd immunity, all of
Absolutely.
that.
There is an opposite paper that I want to cite to you, mentioned in great detail in the Atlantic, which says that mathematical models done both in America and it seems in Sweden, which take into account the fact that the virus affects different people in a different way, and
Right.
also takes on board the assumption, and it is an assumption, that those most susceptible to the virus have died, and therefore those who've survived and recovered or not been infected have other forms of protection. And
Right.
they, on the basis of these two, have calculated that herd immunity could arguably be as low as 20-25%. I know this is not peer reviewed, but it's there in the Atlantic. So, what I'm simply saying is if, on the basis of the serological assumptions of the ICMR survey, we are close to, say, 350 million or 560 million by the middle of September, should the country be worried? Or should the country say to itself, no, this is getting us closer to herd immunity?
No, from where I sit and I see it, I think the country should worry. And the reason simply is that uh, I don't believe that at 20-25% you're going to get herd immunity to a virus like this. Remember, herd immunity depends upon a lot of factors, such as the transmission ability of the virus, the ability of the virus to uh, leave long lasting immunity in people. From whatever we are seeing here, this is a virus that is moving much slower than, for example, a measles or mumps virus, which requires 90% for herd immunity, but it's moving faster than a flu virus, a seasonal flu virus. So I estimate that a good figure for herd immunity is likely to be in the range of about 60%.
Okay?
So if you assume that and if you let herd immunity simply take over, then 1.38 billion people in India translates to uh, about what 83 million. No, 138 crores. 138 crores.
800 million. 800
Yeah,
million.
800 million. 800 million, and if the infection fatality rate is, let's say, 0.5%, you are looking at about 40 lakh deaths.
That's right. I take your point.
If the infection fatality rate is only 0.08%, as ICMR results show, it's much less, but still it's a very significant number. Would any public health system, would any political system allow that to happen in a short period of time?
In other words, if the projections that we're doing based upon the ICMR serologic survey turn out to be correct, it will be deeply worrying. Not, and it ought to be looked at not in terms of getting closer to herd immunity, but in terms of the number of deaths that would follow, depending upon the infection fatality rate you bear in mind.
Right.
Let's
And
look.
may I just add that the second reason I'm worried is that there is increasing data that the immunity is not long lasting.
I'll come to that in a moment's time, sir. Let's take that up later. I want now to look at the situation in Delhi. On the 23rd of June, the number of cases in Delhi was increasing roughly at 4,000 a day. Yesterday, it increased by just 1,246. Meanwhile, we're told that the recovery rate has jumped to 75% and there is no longer pressure of beds in hospitals. Hospital beds are lying vacant. Does this suggest to you that Delhi has passed its peak, or is it too early to come to that conclusion?
Delhi may have passed its first peak because for the last 2 weeks, the numbers in Delhi seem to be going down. But what Delhi has started doing well, finally, is to do increased testing. So if you look at the testing rates in Delhi, Delhi is in the last 1 week, Delhi has done about 88,000 tests.
Delhi is testing at roughly 21, 22,000 a day,
That's
except
right.
on Sundays when it dips.
Yeah. So
Ignoring
what I was coming to is that to find one positive case in Delhi, you need to run 10 tests. On the other hand, if you look at Mumbai, for example, in Mumbai to find one positive one positive case, you just need to do about 4 to 5 tests. The ideal number should be around 20. You should do about 20 tests to find one positive. So you must have a 5% positivity rate.
In other words, you're saying Delhi should practically double the 20, 21,000 tests a day it's doing.
Right. And what I'm suggesting is that Delhi needs to double its testing capacity from here on, because whether it's Delhi or anywhere in India, as you increase the number of tests, you are increasing the number of cases, which tells me that you are testing suboptimally. So the
Absolutely.
number of tests need to go up.
Let me put this to you. I want to come at this point to testing, but before I do, you raise this critical question of what is a sufficient number of tests to do. It's a question that's repeatedly asked in India. 10 days ago, I interviewed the chief scientist of the World Health Organization, Soumya Swaminathan, and she said to me that India will be testing enough when the positivity rate, not just nationwide, but in containment zones as well, falls below 5%. Would you accept that?
Yes, so that's what I was just saying, that it should be 5% or less. 1 in 20 means 5%.
And that means that Delhi needs to literally double its testing at the moment.
Delhi needs to double it, Mumbai needs to quadruple it.
Now, we get told on television that the nationwide positivity rate is somewhere, but it varies from day to day, but it's somewhere in the range of 8 to 9.5%. That means it's a good 4.5% too high.
I did a calculation and the number actually has been falling. If you compare the week of 14 to 21st June, the positivity rate was 7.8%. If you compare the current week, 5 to 12 July, it has gone up to 11.4%. So at this time, we are detecting one positive case in every 8 to 9 tests. And again, this number needs to go up from 8 to 9 to 20, more than double, about 2.5 times. So as a country,
the government is nowhere near testing enough.
No, we're not testing enough. We're not testing enough. But my understanding is that there is a move to really drastically increase the testing capacity. There is a central lab coming up in Mumbai, that is going to be employing an automated RT-PCR system, which will take our testing capacity to about 10 lakhs a day. And it will bring the cost down to about 500 rupees per test.
Okay, we have to look forward to that. Let me at this point put you some statistics that the government frequently cites because the government believes they show that India is doing better than other countries. I'll go through them one by one. First of all, we were told on the 9th of July that India has one of the lowest cases per million. It's just 657 in India compared to over 6,400 in Spain, over 4,200 in UK. But is that reassuring, or is it simply a reflection of the fact that in terms of testing, we do a lot less than these countries? India tests roughly 8,700 per million. Spain tests over 128,000 per million. UK over 178,000. So when the government cites the fact that cases per million is lower than these countries and ignores the fact that our testing is much, much lower than these countries, how reassuring is this statistic?
No, so I just said that we are testing suboptimally. As we test more, we find more cases. And Soumya was right that you need to go below 5%, at least 20 tests to find one positive. And we are nowhere close to that. We are about 2.5 times away from that. So we need to increase testing. But let me get to that per million data. You know, uh, if you look at the death rate per million, again, India's death rate is low at 17 deaths per million population, compared to US, which is 418 deaths per million. Sweden has 548 deaths per million. UK has 660 deaths per million. But that's not true only for India. You look at the entire South Asia, you look at Southeast Asia, it's the same story. Pakistan has a death rate of 24 per million. Bangladesh has 15 per million. Sri Lanka has zero point 0.5 deaths per million. Malaysia 4 deaths per million. Indonesia has 13. Philippines has 15. So this entire region is like that. It's not just India.
In which case, the question that arises is this: is the virus behaving differently in this part of the world compared to Europe and America? Going simply by the huge difference in death rates. And there is a huge difference between 17 per million and 660 per million.
Absolutely, absolutely.
Is the virus behaving differently in what I call our part of the world?
I would say that the host is behaving differently. The virus is the same. There is there is no evidence that the virus that is circulating in India or in South Asia is any different from the virus that is that has circulated in UK or Sweden or US. But as people who live in an area that has a lot of infectious disease, we do seem to have a much stronger innate immune system that controls the virus early on. That's my hypothesis. I mean, it's not been tested, but that's, I think, what is happening. That our innate immunity is much better than people who live in far more hygienic environments of Western Europe and US, and therefore we are able to control the virus much better early on before it progresses into severe disease. Uh,
Would you therefore agree with what Health Minister Harshvardhan told the Economic Times on the 23rd of May when he said the virus is not that virulent? And I'm not just talking about India, I'm talking about what we call our part of the world. Would you agree it's not that virulent? Not because the virus's strain is different, but because the host, as you put it, has innate immunity. We've been exposed to so many diseases that we have an immune system that is better as a result. The
yeah.
virus is not that virulent. Would you agree?
So I will partly agree with the health minister, but again, it's a matter of what you compare it to. If you are comparing this virus behaving in the West and behaving in South Asia, yes, I agree. But if you compare this virus to, let's say, a seasonal flu virus, then I don't agree. Seasonal flu virus, the the case fatality rate is, somewhere in the range of about 0.05%, whereas, we are talking about an infection fatality rate of about 0.5%. So this virus has at least 10 times more mortality associated with it than seasonal flu. So it depends on what you compare it to.
Absolutely. But I think the health minister, if I can interpret him, was comparing the impact of this virus in our part of the world with the impact on Europe and
Oh,
America.
that I agree. Then I agree with it. Yeah.
There
Yeah.
you agree with it.
Yeah, I agree.
Finally, for this part, before I take a break, looking down the road over the next 3 months and bearing in mind the sort of projections we've discussed earlier, which at one level would suggest we could have as many as 560 million cases. Hopefully, we won't. What's the advice you give the government about the strategy they should follow?
The strategy is the same that we have been saying from day one: test at scale, trace contacts, and isolate. And when you isolate, isolation needs to be done in a place where people can identify with. The trouble has been that people are not going into isolation simply because they're not really comfortable with where they are being isolated. Those of us who can get isolated at home should be isolated at home if we have very mild disease. If not, maybe community isolation is something that we should think about. Village-based isolation, community-based, mohalla-based isolation, instead of being isolated in a place that you don't identify with.
This,
So, I keep coming back to controlling pandemics with trust. And when there is a trust deficit, people don't comply. And we've seen a lot of that happening this year.
you're suggesting, aren't you, Dr. Jamil, that the strategies that are devised need to be fine tuned so that they're reflective not just of the district context and conditions, but perhaps even mohalla context?
Absolutely. Absolutely. Go local. Because every locality, every district, every city is different. When we talk about numbers across India, we think that India is one unit as far as the virus is concerned. It's not. Mumbai is very different from Arunachal Pradesh.
And so, in each of these contexts, you need a strategy that is designed for the peculiar needs of that area.
Absolutely.
A nationwide approach, a one size fits all approach, is the wrong way.
Is rare. It rarely works.
Let's take a break at that point, Dr. Jamil. When I come back, I want to turn to the disease itself. And in that context, I will take up this question about how much immunity do you have and for how long does it last if you get infected. But I also want to discuss with you, are there aspects of the disease that we're only just getting to know? Is it attacking organs and parts of the body we didn't think earlier it would attack? Is the recovery taking longer and proving more torturous than we thought? And finally, I also want to raise with you the possibility, as raised by scientists to the WHO, is this now also, in certain specific conditions, an airborne virus? And does that make it more deadly? All of that in a moment's time after the break.
Sure.
Welcome back to a special interview for The Wire. In part one, we discussed just how fast is the virus spreading in our country and are we in control of the situation. Now I want to talk about the disease itself. My guest is the CEO of the Wellcome Trust DVD India Alliance and one of India's leading virologists, Shahid Jameel. Dr. Jameel, let's talk about the disease. First of all, there are increasing concerns that the disease may not just affect the lungs, but it also seems to affect the brain, the heart, and the kidneys. Dr. Guleria, the director of AIM, says that there's an increasing number of patients coming who are suffering strokes or neurological disorders, not just respiratory problems. The Guardian newspaper in England has reported that the UK has evidence of 40 or 45 cases where severe brain damage was done by the virus. So is it now beginning to be the case that this virus affects many more organs of the body than we initially thought it would?
No, that's true. That's what the data is showing. That it's more of a multi-system infection or multi-system disease, I should say. What is not clear is whether the virus is actually infecting many of these organs, or is it an indirect effect of the cytokine storm, the inflammation that it is causing? So it could just be a manifestation of the inflammatory response that the infection is causing towards, in people who are more severely ill.
Absolutely. Just for the sake of the audience, I'll explain a cytokine storm is the consequence of the body's own immune system sometimes
Right.
overreacting. And
Right.
this virus may actually be pushing the body to overreact, and that may be why the
Right.
brain or the heart or the kidneys are getting infected.
Right.
A second problem that seems to be emerging is that it seems that recovery is both prolonged and slow and sometimes very tortuous. Again, Dr. Goleria says that there are a lot of patients who recover, but their lungs remain in bad shape and they need oxygen even when they go home. The
Right.
well known CNN anchor Richard Quest, who got the disease in the middle of April, has said even today his body doesn't feel quite right. So, are we discovering that recovery in many instances is long, tortuous, and sometimes very difficult?
No, absolutely. And I know somebody in UK who's himself a chest physician who got infected in March. And I was speaking to him, and he said that he has never ever felt so ill in his life. He felt, he said that it appeared that his lungs were on fire. And this is somebody who treats, chest diseases. So absolutely, I mean, this virus is showing some very very strange features. We don't fully understand whether it's all virus driven or is it all part of that inflammatory response that the virus triggers. Because when lungs require oxygen, it tells us that there is fluid accumulation in the lung, fluid and pus accumulation in the lung, which happens because the body's immune system is trying to fight the virus in the lung. And in this fight, there are all kinds of cells that are targeted to the lung. And in this battle between the virus and the immune system, you leave a lot of debris, and that debris accumulates in the lungs, in the air sacs, which are required for oxygen exchange between the blood and the lung. So it's possible that these air sacs are not regenerating, especially in older people who don't have regeneration capacity as much as younger people. It would definitely cause much more problems. And also if you have been a smoker, or if you have other comorbidities.
And this is why recovery is prolonged,
Right.
slow, and tortuous.
Right. Absolutely.
Let's come against this background to the question that you raised in part one. How good, how long lasting is the immunity that a person has if he
Right.
or she gets the virus? Do we have any idea how long it lasts? I initially it was believed it may be lifetime. Then
Mhm.
it was thought that perhaps it will be for a few years. But now, in fact, King's College in London has done a survey or a report that suggests it might not last more than a few months.
Right. So there was a story published in the Guardian 2 days back, and it was based on uh, a paper that appeared from King's College London in medRxiv, which is a preprint server, and that showed uh, that if you look for not just antibodies, but the neutralizing ability of plasma, which is more important here, that went down to baseline in about 4 months from the time symptoms appeared. Uh, there may still be antibodies, but those antibodies may not be capable of neutralizing the virus. So we have to, understand that all antibodies are not neutralizing antibodies. Only a subset of the total antibodies are neutralizing antibodies.
But this also suggests that if the effect of the antibodies disappears after 4 or 5 months, people could be prone to multiple infections.
Maybe, but maybe not. What has not been looked at is what sort of a memory response has been left behind by this infection and how quickly that memory can be, uh, how quickly that memory comes into action. So, what normally happens is that when we get infected the first time, we raise an immune response, but at the same time, we raise a memory to that infection. And next time when we get infected, the memory kicks in and very quickly produces the antibodies and the T cells that are required to control the infection.
So,
So,
something.
what we see now is only antibodies. We have not seen how good is the memory response. And those experiments take time. Many people forget that we are only 6 months into an outbreak. We don't have enough time for patient follow up. This King's College study has followed people for 4 months. Uh, this is possibly the longest that I have seen. Most studies have followed for 50 days or something like that.
Can I put this to Dr. Jameel? One hope that, in fact, even if the antibody immunity doesn't last for very long, one hope that we're still protected is what you call the memory response.
Absolutely.
Secondly, there are also studies that suggest that there's a certain amount of immunity that the T cells in our blood might be providing us, and that is
Yes.
still being studied. How do you respond to those studies that say that we might be protected by the T cells?
Well, I mean, it's a combination of antibodies and T cells that protect against any viral infection. So that's not something new to this viral infection. It's just that the antibodies will protect from virus that is outside the cell, whereas T cells will go and kill virus infected cells. So that's the difference. So the first line response is the antibody because it has to neutralize virus before it enters the cell to replicate. However, when T cells are present, the right kind of T cells, they will seek out virus infected cells and destroy them, and therefore destroy the infection.
Some interpretations of the studies on T cell response suggest that we might have more protection against this virus than we initially thought we did. Would you agree with that line of thinking, or is that perhaps exaggerated?
Well, I haven't seen enough T cell data, especially the memory recall data, to be confident of that.
Okay.
I think what would be critical is what is the memory recall? How quickly do people respond to the next infection? Does the next infection become a disease or not? See, here we are not worried about somebody getting infected. One is worried about getting disease. And we have to distinguish between infection and disease. Getting infected is fine. We're getting infected all the time uh, with all kinds of things. But as long as it doesn't produce disease, we shouldn't really worry about it.
And that's where the memory response becomes critical, isn't it?
Absolutely, absolutely.
My last question, and it's something that has emerged only recently and it's worried people. 239 scientists have written to the WHO to say that they believe that this disease is not simply passed on by droplets, it's also passed on airborne through aerosol. And in response, the WHO has accepted that in certain limited conditions with poor or no ventilation, it is an airborne disease. Now, does that make it a more dangerous disease, or does that only apply to very limited specific conditions?
Well, we have to really understand what airborne really means. The virus is thrown out of the oral cavity of an infected person in droplets. Now, these droplets can be of varying sizes. The big droplets contain the most amount of virus, and the big droplets fall very close to where you are. Let's say you're coughing. So, big droplets will fall very close to where you are. The smaller droplets will travel, but the smaller droplets have fewer virus particles in them. And the smaller the droplet becomes, the it the number of virus particles in that droplet also go down. So when we are talking about airborne, it's not like the virus is sort of floating around in the air. The virus is still part of droplets, but really very, very small droplets. And these droplets have such low levels of virus that you need to inhale a lot of those droplets before you will get infected. So you must be in the direct line of flow. So for example, if you're sitting in a restaurant and the air conditioner is blowing and it's blowing from behind somebody who is infected and coughs and you are upstream of them, then of course you will get it. But I think for all practical purposes, there is too much being made out of this airborne thing. We are losing track of the fact that if everyone wears a mask, then everyone is protected. The person who is infected doesn't throw out the virus in large quantities, and the person who is susceptible doesn't inhale them.
So does this mean that mask wearing continues to be essential, but does it also mean that the 2 meter social distancing is sufficient? We don't need to be further apart?
2 meters, one shouldn't really see it as exactly 2 meters. If one is wearing a mask, you may not even need, that 2 meters. It's simply based on the travel capacity of the large droplets that are very rich in virus particles. Uh, and frankly, many people in our country can't afford to have a 2 meter physical distancing. But each one of us can afford a mask.
And the important thing you said about the belief that this is transmitted in an airborne way is that the droplets that travel far are very small and have a very, very small viral load, and therefore the danger that they pose must not be exaggerated.
Exactly, exactly. I think in the last few weeks, too much has been made of this airborne transmission. I get calls from people in my RWA, and they say, now we hear that the virus is airborne, and they're so scared they're not coming out of their houses that the virus is airborne. I mean, the virus is not out there just hanging around to grab you. Uh, it's I think proper communication is really very, very important for these things because
Unfortunately, that level of proper communication, which should have come from the government or for doctors working with the government, hasn't happened. I don't believe any of the doctors working with the government have explained airborne transmission and why we shouldn't panic in the way you just have. I'm particularly grateful to you for having made this clear. Thank you very much for this interview, Dr. Jameel. Take care, stay safe.
thank you, Karan. Pleasure. Thank you.
To receive instant updates on all videos from The Wire, click the subscribe button and hit the bell icon. Pay to support independent journalism. Click the link in the description and choose the amount you want to pay.